2015. And as commissioner, she established her top priority by creating an Office of Population Health. That office has been invaluable in promoting strong collaboration among hospitals, local health departments, and healthcare providers. So welcome, Kathleen. Thank you.
Thanks so much, Kendra, and I appreciate the nice welcome. And I actually said, feel free to cut away and be a lot shorter, but I appreciate when you put it all out, because what you did was actually hit a whole bunch of people are on this call today that I've interacted with over the years that have really been, I think incredibly influential in advancing like better health in New Jersey. This started, and I think about it, like when we started talking about, how do we improve both physical and mental health, and how do we start to integrate those? And a lot that are on the call today were great advisors and great supporters for it. And I'm so happy to see the governor, is bringing that back again, and is, putting some, money towards how do we get ourselves on the right pathway of treating the whole person. So that's pretty cool. I got to tell you, I want to be really respectful of time, and I know I've got a limited amount, and I've got like way too much information, because as I always do, I wrote the slide deck last night and I finished it at about 2 a.m. So we're going to skip a lot. You don't have to worry. There's like way too much information. And I got to say, I am very appreciative. Tom said he's going to advance slides for me. So I'm going to let him go ahead and like pull them up, and, stop me if you have any questions, but I'll also try and go as absolutely quickly as I can. And I'm not going to be reading slides at you, so we might like jump forward here and there along the way. Does that sound okay? All right, awesome. Listen, one of the things I really think about is, where are we at from a mindset perspective around healthcare in New Jersey? And, one of the things, and I'm putting on the hospital perspective here, is that we know that hospitals have always been like the organizations that matter on healthcare delivery. They're the things that matter when we talk about serving vulnerable populations. Nothing like that really came home to me more than, knowing that the doors are not just open 24/7, 365, staffed and ready to take any person that walks through the door, but again, that they take any person regardless of the ability to pay. And what really, like, I think drove that home for me was that, there was the big acquisition of Village MD by one of the big retail pharmacists. And just in the past few days, they said, God, this doesn't make enough money for us. We're going to start closing down those, Village MD offices that we put into our retail pharmacies. That's not something we can do in the hospital side. That's not something that you can do when you're not for profit on the, long-term care side. Once you say you're going to take Medicaid, you're in that position of you take all comers. And so that's why it matters so much when we're talking about the delivery system, when we're talking about vulnerable populations, and when we talk about what's really happening within our communities. How do we make sure that we enhance wellness, that we support prevention, that we get people into the best possible health status that you can? And that's one of the things that we saw during COVID, right? Like, folks weren't in a great health status, and we didn't have a really good delivery mechanism for figuring out how do you get testing done. The hospitals stepped in, they stood up testing sites. If you were in South Jersey, you saw each and every one of your healthcare organizations stepping up, helping out with testing. Then it comes time for treatment. We all know where you drove to. Then it came time for immunizations, and we saw these sites being set up everywhere throughout South Jersey. And whether you were at the Morristown Mall, whether you were down at the convention center in Atlantic City, people were going everywhere to get immunized at sites that were stood up by hospitals. And you think about this, it's one of the ways we help to protect the community and advance well-being, but it's also like not like the best solution that we're in the midst of a pandemic and trying to build a plane to deliver new and innovative care and therapies. And so we've had a lot of lessons learned out of that. But probably the best is that we've got to make sure that we continue to work and build partnerships. And we've seen this during COVID, how critical it was. Without these partnerships, and I think about the employer community, where we were getting calls right and left saying, we've got PPE, we have, and construction, by the way, I remember sending us, N95s and other face masks and face shields, for example. We had, our, had ambulatory care sites that we're saying, we have oxygen, we can get that to you. So, really coming together and saying, what can we do? And how can we partner? And I'm so glad we have things like, the Southern New Jersey Development Corp, because these relationships you're building today matter when tomorrow comes and we're dealing with a crisis, because it's a lot easier to pick up the phone when you've already broken some bread. So the other thing we see is that you got to have like new levels of ideas, ambitions, and imagination to deal with what is an incredibly complex and difficult external environment. Can you pop over to the next slide? Okay, so next up is I wanted just to run through this. You guys know it. You live in South Jersey. I'm sure that your friends from Inspira have told you over and over again. And if not that, well, I know that Anthony DeFabio never stops on this one. 38 most vulnerable zip codes in New Jersey. And you know that it includes Camden. It includes, Cumberland County. It includes areas of Camden County that, other members are, within. It includes Atlantic County. So you look all over, and I just wanted to kind of highlight the 38 most vulnerable zip codes. In those, nearly 1 in 5 lack health insurance. 28% of the households receive SNAP. That's that supplemental nutrition assistance benefits. The median household income is less than $39,000. 14% are classified as disabled. Nearly 4 in 10 are on Medicaid. 25% do not have a high school diploma. Nearly 3 in 10 births are to teen moms. Nearly 1 in 10 babies are born at a low birth weight. More than 14% are unemployed. 13% of households are in a food desert. 4.7 years shorter life expectancy versus the state median, and 15% of the households have limited English proficiency. Need I say more? What it tells us, what really matters, and what we have to pay attention to is this emerging focus on what we call social determinants of health. So if you can pop to the next slide. Oh, and then the next one. Sorry, there we go. So you take a look at this and you say, you know what? As employers, we all worry, is insurance affordable? What are the hospitals doing? Are the hospitals the cause and the driver for insurance? I kind of went through that big picture, and I wanted to really highlight what's going on today is we've got, folks that are really suffering. You got that list, 38 most vulnerable, and you got like what their status is from things that healthcare can't solve to. That's not a medical care situation. Those are socioeconomic factors. And what we see is that socioeconomic factors are actually 40% of the reasons why people end up needing healthcare, clinical care through the hospitals. Behavioral health behaviors, that's 30%. The physical environment, you don't have a safe place to exercise, you don't have a safe place, to go and walk or sit outside, or you're in a place where environmentally there's a lot of pollution, and we've been seeing a lot of information about that over the past few days. That impacts. Finally, the piece that like really is tied to medical care, your actual health, is 20%. It's all these other things that are going on around that impact the health status for individuals. So, if you don't have housing or it's unstable, if you don't have healthy food, and how long have we been talking about like the need for a grocery store in Camden City itself? How in the world do we expect people's health statuses to improve? So you want to pop to the next slide? Okay, so what I like to say is from wealth comes health. And I want to give you this picture because for me, this maybe is the most telling thing. So I just wanted to, the numbers aren't really important, but on the far left, it's the median household income. Blue is what is the lowest median household income in the entire state. And you will see that we have Essex County, Atlantic County, and Cumberland County in those three. The next, when we take a look at that, the next lowest is in yellow. That picks up a good chunk of the remainder of South Jersey because you're picking up Ocean, Cape May, Camden, Salem. And then, the next level up, which is, green, is in green, that brings you Gloucester and Burlington. What sticks out to me is that the wealthiest counties are all in the north. So that just, gives you a way of, comparison. If you go to the middle picture, what you'll see is what we like to call preventable admissions. So we've gone through what your household income is, and now you get to preventable diabetes admissions. And what I want you to hone on is that if it is in blue, that is the greatest number of preventable admissions, and that was actually for diabetes in Salem County. And I just wanted to point that out because, the most preventable was Cumberland County. It's in purple. And I wanted to point that out because one of the number of individuals that reside there, and number two, because you can compare it to what the relative median household income is. So Cumberland County in blue on the left shows you it's one of the lowest median household incomes in the state. And then you go to the middle picture and it's in that lavender color, and you see that they have the highest rate of preventable diabetes admissions. And then the third picture on the right, the far right, is Cumberland County again, showing that it had the most preventable congestive heart failure admissions. Like there are ways to control that type of chronic condition, but because people's social determinants of health are not being addressed, they themselves, end up in a position which, isn't really great, for their health, for their well-being, for you as employers, because it's missed days of work. It's also, the impact it has on your, on the cost of your healthcare coverage that you provide to your employees. So just really quickly, next slide, kind of a gut level. This was just a list of all the different preventable hospital admissions if we had actually addressed the social determinants of health. And just to give you a quick sense, looking at this, the summary is it was at more than 231,000 preventable hospitalizations to the tune of $4 billion. You want to go to the next slide? Okay, so population health is all about the integration of clinical and social. And what I just try to show here is around the individual, there are a ton of supports that are needed. I put aging in here. There's aging that's needed for our aging population itself. There's also aging because you've got the sandwich generation. They've got to figure out how they can help care for aging parents while they're still caring for other dependents in their household. You've got community supports that come into play. You've got education. You've got employers in the role that you play in supporting a workspace that prioritizes mental and physical well-being. You've got housing and nutrition, and then you've got the physical health and the behavioral health that we have to deliver on. All those supports need to be addressed. They need to be available and accessible and equitably provided to improve the health status. And then you take a look back and you see the impact it starts to have on the economic situation for the residents of our counties. And that's one of the big differentiators. If you take a look at the racial makeup of a Hunterdon County versus, let's say, a Cumberland County, it is about similar, but the economic makeup is much more advanced. They're much stronger economically. The median household income is more than $30,000, is more than $30,000 greater a year than in Cumberland. And I take those two as comparisons just because they're both rural communities. Okay, next slide. What nonsense did I write? Okay, here we go. Quick, I did this environmental scan. This is just a whole bunch of issues that are impacting, what's happening with hospitals, which means what's happening with employers, which means also what's happening with your employees, what's happening with the residents of our communities. The biggest thing really ties to the inflationary pressures. And we all know when money gets tight and you're feeling those, it starts to impact the mental well-being. It starts to impact people's physical well-being. And make no mistake, that post-COVID number where we hit 9.1% in June of 2022, that was off the charts. And that's something we're still recovering from because it forever changed our landscape. Everyone saw it. You saw that the cost of labor went up, the cost of supplies went up, and you're trying to actually account for it in what you charge. But there are challenges. There's challenges, as employers try to do that with their product. And for hospitals, there are a lot of challenges to it as well. Despite that, like gigantic, I just say hockey stick on the inflationary side in June of 22, where it went all the way up to 9.1%. We also saw, currently that the inflation rate is at 3.5% through the end of March 24. That's up almost 0.5% from the month prior. So, when we look at this, inflation isn't over. And yet, as we're, continuing to struggle, I think, with some of the challenges, I will say that hospitals have been doing a great job to manage what the pressures are. Typically, medical inflation is a lot greater. There is so much effort coming in to control costs. They are actually trailing inflation. We're at about 2.1% through March of 24, just to give you a point of comparison. So if you want to pop to the next slide, one of the things I wanted to just sort of highlight, when we talk about what was the impact of inflation and how did it really reset our landscape, the biggest thing we saw is that, workforce shortages worsened for us and the labor costs skyrocketed. We had to rely, and we still have to rely on travel nurses, respiratory therapists. And what we saw is that the hourly rate for those temporary employees jumped more than 200%. So you've got some things that you can do to control costs, but the one thing is, as a 24/7, 365 operation where you take all comers, you got to make sure you've got staff that's there and able to help care for. And what we saw is that during this time period, our hospital spent 62.5% more for travel RNs than they did at the start of 2020. To put that into like real dollar terms, the spend went from 220 million to 670 million statewide for qualified staff. So this is a really big deal. We've seen this impact of staffing. It continues to play out. And while that's going on, we're also dealing with all sorts of like shortages. There have been PPE shortages that everybody knew about. We came out of that, and I could ask the question, if we were together, but I know a bunch of you would raise your hand. Who remembers the infant formula shortage? Who remembers the diaper shortage? We're still dealing with things that are tied to plastics and to smart chips. So lab, kits and reagents, the specimen bottles that you put blood in, for example, devices that use the smart chips. So that's a lot of the medical devices that you have in play. And then you've got things like albuterol. And then, of course, we're hearing the huge story that's taking place on the behavioral health side around ADHD medications. So there's a whole bunch of products that get, kind of looped into this. You want to go to the next slide? So then, as we look at what's happening with our workforce, this pandemic really took a toll. We know it. It exacerbated burnout. We had an aging workforce in our hospitals. Just to give you a sense, about 1 in 4 nurses are between the ages of 55 and 65. In other words, they're getting really close to the retirement age. And so I want you to think about like what the past years have been like. They didn't just go through a pandemic with COVID, but then right after that, we had a really severe respiratory illness season. And it was flu, it was other types of severe respiratory illnesses, and the population in hospitals just skyrocketed again. This is where you almost don't catch a break because we're bouncing from one thing to the next. So when you've got all of that taking place, and then you've got this gigantic regulatory, burden, because I can't think of anything that's as highly regulated as what our hospitals are. You're pretty limited. You've got, hospitals, you've got some things in transportation, you've got some things like I'd say probably in our utility side, and that's about it. So when we talk about a lot of regulation, I know some of you will get it. It's the burden that comes with it. We're trying to put a cost to that right now, but that adds for every patient that comes in. You have a federal one, you have a state reporting one, that adds tens of thousands of dollars to the cost of care for that patient alone. So you've got all that going on. And hey, remember, this isn't why nurses and doctors signed up to be nurses and doctors. They wanted to care for patients. They wanted to be bedside. They're now busy like doing reports and entering data, and they're spending a big chunk of time with it. So we've got to figure that out, because if we don't, we know that we're going to continue to have this gigantic emotional toll on our different leaders within the healthcare systems. And one of the things that really jumps out at us is the impact on our nursing workforce, on our physician workforce, but we have seen it for our environmentalists, the folks that come in and clean rooms. We've seen it on our dietitians, our nutritionists, our respiratory therapists, our mental health techs, the whole gamut of, supports that go into running a hospital and providing care. They're all feeling this. You want to pop to the next slide? So, we've got all that going on. I talked a little bit about how the workforce is aging, but another thing that we're looking at is our population itself is aging. We've got 1.5 million senior citizens today. It's about 17% of our population. That's going to go up to about 24% of our population in the next 6 years. So I want you to think about, like, we've got a population, and I can tell you, I'll give the little personal story here. I definitely know it. My mom is one of them. She's 81 years old. And, I got to say, you got to meet her where she's at. She is tech and digital savvy. She's got her Facebook, she's got her Snapchat, she's like, doing Instagram. She's traveling right now. She's, FaceTiming us while she's away. And that's really important. But she's also really about data privacy. And so, every article, every hack, the fact that like, cyber attackers are now targeting individuals. She's really tuned into that. That's the norm for this new, population of seniors. But they also get the power of it and how it helps to build social connections and how they can actually leverage what's available for technology to improve their health, to improve their wellness, to get care, online through telehealth and to age in place in their homes, for as long as they can. Those things are all important. That's changing. And that's also changing what we're seeing. One of the other things that we're seeing with our aging, population, though, that's come out in the data. We did a report on this last year, but we had more than 20% of our inpatient admissions had 8 or more chronic conditions. Think about that. It sounds really bad, and it is, because there's a few things taking place. One, that social determinant of health picture we started with earlier. Number 2, people are living a whole lot longer. And number 3, there's lots of medications you can take that mask things and let you get by. And unfortunately, they delay care, and it all hits at once. Once there's an episode, other things that had been managed all of a sudden start to fall, apart. And Kendria, I see you shaking your head. This one. Okay, next slide. So really quickly, health equity totally matters. I already, kind of went through some of the big numbers. You can pop to the next slide. And as we continue to look at this, all I'm going to say is that as we continue to look at equity issues, we know that women have been impacted. Black and brown communities have been impacted. We're seeing it on the employment side, and we also see that disproportionately, that if you have lower educational attainment, you happen to be a person of color or you happen to be a woman, and that has impacted what your income levels are. And right now, on the women's side of the fence, we saw that about 50% of the workforce, women workforce, exited since the start of the pandemic, despite making up like 48% overall. So that's like a big number to keep in mind. Next slide. Okay, so we've got lots of people that we've got to figure things out for. And the one thing I do want to make a big pitch around, and I know that you're looking at in South Jersey, but you're also one of the areas that really suffers from the lack of really good broadband coverage. And let me say, the lack of broadband coverage, it impacts the finances, it impacts the health of many, many people. We know that roughly 26% of New Jerseyans don't have broadband. And we know that if you have a lower household income, that you're less likely to have broadband. And we haven't figured out how to even get broadband so it's good and consistent and available and accessible into play as well. So a lot of things taking place there. The other thing that I just wanted to sort of highlight, as we're looking at it, is that we want to meet people where they're at. We want to make sure that they get culturally competent care. We want to make sure that the people that you employ get the same sort of access and they get the same sort of connection that they do in their workplace. But the only way we can really get there is to meet them where they're at. And we have heard they want to do telehealth, but we need to make sure that we've got stable connectivity to make that happen. Okay, next slide. Behavioral health. I almost feel like I shouldn't even talk about this because we've got a bunch of experts that are on the call today. And I know you guys are, but just a couple of quick things. 41% of adults reported at least one behavioral health condition related to the pandemic. Anxiety, depression, trauma, stress-related disorder. I think they can all tell you that that is unheard of, the amount that we're willing to talk about having a behavioral health issue. If we had looked at this data pre-2019, you would have seen that it was in the high single digits. Huge change. 32% of adults said that they needed but were unable to get mental health services from March 2020 to March 2021. And that's when people started to self-identify more, recognize what was taking place. But we've got a system that needs to scale up to meet what the demand is. That's what the story is there. And then, of course, we're seeing a lot playing out for particularly our youth that are LGBTQ. So we continue to take a look at that. We're looking at what's happening with fatal overdoses. We've seen the sad impact on the maternal and child health side with moms, but we've also seen more broadly within the community that the number of fatal overdoses has been increasing again. So we've got to like get our hands around this, and we've got to make sure that we have the availability of providers and that we've got the services, the costs for them that are covered. Because without that, we're going to have people that are going without. So there's a lot of work to be done. And even for smaller firms that can't afford to do EAP, there are things you can do to support the wellness within your workplace. Okay, next slide. Okay, you don't really need to see this one. Go ahead, next slide. It's a lot of data. One of the things that you touched on was telehealth. Just quick numbers on this one. Telehealth utilization 78 times higher than it was in 2020. So just that talks about really, giving people and meeting people where they're at, or like I like to say, from the industry that gave you the waiting room. Thank you very much, hospitals and doctors' practices. We've got it. You don't want to be in one, and we've got to be quicker, and we've got to, be better utilizers of your time. And so even within our hospitals, you see a lot more, electronic information being made available, giving you sets of ideas of times. When will you be seen? How long will a procedure, take if you're waiting for a loved one? Way to contact you so you don't have to sit in a waiting room and can do things and come back. A lot more from a communication perspective. And you see a lot more utilization of things like, the My Chart that many of you probably use yourselves now to interact with your doc, to get your prescription, to send a quick message. And that's how we like to do business, because we do live in the generation of immediacy. So, we know that many consumers say they're planning to continue using telehealth moving forward. And, that's one of the reasons why people actually want to switch who a provider is, because they don't want to be stuck having to just do in person. They want telehealth as an option. Okay, next one. And here's my final thoughts on it. And here we go. Hospitals need to work with employers. And when we do so, we have the ability and the responsibility to drive health improvements for our residents, for our employees, while respecting their dignity. That's got to be what's at the heart of this. Meeting people where they're at. Meeting them where they're at means doing things that are culturally appropriate, actually making sure that they're linguistically appropriate, making sure that from an aging perspective that they are appropriate, because that's part of the dignity of the person. And that's one of the things that institutions like, our employment sector, like our healthcare sector, that we have an obligation, and that I think we've done really well partnering, historically, and that we're going to continue doing really well moving forward. But what it requires is that we start getting creative and innovative on some of the things we can do, because we know that we are, have to jump in there, that this is not a solution that government's going to come up with for us. That we've got to be a key component of it. Government's got a role, and they've got a significant funding role, but the rest of us all have to jump in as well. Because when we do, we're setting that healthcare system of tomorrow, the stage for it. So, one of the things that I like to say is it's the one where we're investing in wellness, not just sickness. And, I could tell you all of the, hospitals on the phone, all the behavioral health providers, all of those that provide long-term care supports are going to tell you the same thing. We'd much, much rather be spending the money and the effort on those where you couldn't prevent it, rather than the situation where you had over 200,000 people that could have avoided a hospitalization had we had the right wellness and prevention supports in place. We need to make sure that we're connected and coordinated with a lot of different partners. It's funny, we just did our ability modernization here at NJHA, and we did everything from, having somebody in and talking to us, what do we do, to be as green as possible, to, what do we do to ensure that, the air that we pump in is fresh, air. How do we make sure that we do things from, a lighting and window, cube placement so that we maximize lightness and brightness? How do we create more collaborative spaces so people want to come back together? And one of the things that we really took away as we talked to all of our staff is that, in today's world, everybody kind of wants a little bit of everything. They want a hybrid environment. When they do come to work, they want a community. And we've got to figure out how do we foster that too. And that thought of community goes beyond what just happens in the workplace, and it extends into the actual community where people reside, the actual community where we employ. So, keeping that in mind, when we do that well, and when we connect and when we coordinate, we start to address the social determinants of health, and we start to engage and support people in their whole health, physical and behavioral. Because if we do all this right, that's how we help our diverse and our aging populations to get services and to get health and wellness prevention where they're at. And that's what allows us to continue to deliver safe, quality, affordable, and accessible care. So that wraps it up from my perspective.
Thank you, Kathy. That was just a phenomenal presentation. Personally, I could discuss these things all day. This is exactly, what we need to focus on. You've touched on all the important points about need and about shortages. So thank you very much. I know for me, just a few weeks ago, we were reviewing statistics on behavioral health workforce shortages, and the projections now are that we are facing a 71% shortage in certified and licensed clinicians and nurses to meet projected needs. So the shortages are real, the needs are growing, and we have to figure this out. It's crisis proportion. It really is.
I absolutely agree, Kendria. I should mention that we will be issuing a report, probably a series of reports starting in late spring, this spring. But we had looked at 31 different positions across the continuum of care. And we looked at what the supply is, what the demand is, and what we need to do to bolster it. And so, that's part tied to partnerships. It's also part tied to how do we rethink care delivery? What are new models look like? And I know that we're working with ONL to put on a program about care design in the fall for the same reason. But this is something that we're looking at care design within the acute. We're going to be looking at care design as it talks about the continuum, because we've got to talk about what do discharges and things like that look like. We need to talk about that integration of behavioral health, mental health, and physical health. So we've got a lot coming down the pike, and it's all workforce driven, but it does require us to relook at what care looks like. So I appreciate you mentioning that.
Yeah, and for me too, I think long-term pipeline workforce issues, we've really got to look at how we might be able to really invest in high schools and try to engage young people and get their interests early on in the healthcare fields, the behavioral healthcare fields, and really further develop the curriculums and give internships and credits so that the students don't face necessarily these enormous burdens. If they can get some first year credits, if they can get some first year education and real hand in hand educational opportunities with the healthcare systems, I think that will go a long way to help build that pipeline. But I know I could talk all day about that. So I'm going to stop and ask others what questions and comments you have for Kathy.
Kendria, this is Kathy Scullin from Inspira. I have a question. Kendria, first, I just want to say thank you for inviting Kathy to the meeting today. I agree, it was very informative. And, we, as Kendria, as you know, our colleagues on this committee, certainly Brianna from Inspira and Aaron from Jeff and Anthony from Cooper and the other Anthony from Ascenda and Casey from Virtua, we're some of the largest employers in the communities that we serve. And we're all about trying to expand patients' access to care as best as we can, despite all the social determinants of health. And Kathy Bennett, this question is really for you as it relates to the unintended impact of legislative mandates, in healthcare. Can you give us your insights and thoughts about how, what some of the unintended impacts of legislation are and how we're working collaboratively with our partners and elected officials to ensure that we continue on our mission to provide care?
Sure. Are you specifically asking about the ratio that's currently?
Well, that's the most controversial one, but even non-compete clauses and things of that nature, there's a lot of stuff happening in the last week, I think, in terms of what potential impacts there are. Maybe not for not-for-profits, but maybe for others.
Yeah, I think these are great questions, by the way, Kathy. And this is, the thing I think we've been grappling with. At the moment, we've got, something called a nurse staffing ratio that's being floated, for example. And what it, says is that, every single function that happens within a hospital, the understanding, from the legislative perspective is that it really gets performed by the nurse, that nurse is the patient facing. And so what they, did is said, okay, and because that's what we believe, we think for each patient, for example, if they're like on a med surg floor, which is, sort of that lower acuity. I mean, you're sick and you're in a hospital, so you're really sick, but it's not like you're in an intensive care unit. They created a ratio and said for every one, there has to be, for every one nurse, it's a max of like 4 patients. And for every 7 patients, there has to also be, along with that, one sort of, support person for the nurse. And the way we kind of looked at it, and why we say that this is kind of a big burden, is if we actually did what the legislation required, we would have to add about $800 million to cover about 2,800 new nurses to be employed. And by the way, that doesn't assume that everybody's an FTE, because we have a nurse shortage, like no two ways about it. Not just here in the state, but nationally. There aren't, more nurses are retiring. There aren't enough new nurses coming in, and those needing healthcare services and hospital services is going to continue to grow because of that aging population that we talked about. So think about 2030, where 20 plus percent of our population is a senior citizen. You need more people to help deliver care. So give you kind of a context on it. If you looked at like all the hospitals in New Jersey and put them all together with how much profit that they have, it's just around $900 million. And if we actually did what was required by the legislation, we would wipe out the profit. So it would be at best break even. And on top of that, you wouldn't do things that we would, typically do, which was support continuing education, support innovations in care delivery, support, not just innovations, but care design, support the building of new structures. I just heard everybody talk about what they're doing for new building. The impacts of that are huge, because if you think about the ripple effect on the economy, hospitals contribute about a quarter to New Jersey's GDP on an annual basis. I take a look at what goes into on salaries. We're about $10 billion that we pay in state taxes, income tax on salaries. When I put all those pieces together, I think that it's actually not just chilling, but it's going to cause our economy to stumble. And it sounds really easy, Kathy, right? Hey, it's just a nurse staffing. We just want to have 1 to 4. Well, 1 to 4 means $800 million. That means that there's no money left over to do anything. And that also means we're going to think about what we maybe can't do as well. What services are going to have to close? It's kind of interesting. Everybody expects the hospital to basically be able to do just about anything that you need when you're driving towards that, blue H when there's a problem. Well, what if you get to the blue H and you find out that those services that don't make any money, that are actually operated at a loss year over year, all of a sudden aren't available? Or here's this, you didn't have that ratio and you had to actually close your doors and go on divert and say, oh, no, you came here, but we don't have the ratio. Go down the road, and go, 10, 15, miles down the road and go to that next hospital. Maybe they, met the ratio today. And that's the part that's really been problematic, I think. So that's one of the big challenges. The other one is just the workforce impact. I mean, I just don't know any hospital that says that we expect the nurse to do everything. We're all trying to get to that point where you get them to really quarterback a care team. And so, if somebody gets a hip replacement, I don't want to see the nurse out in the hallway helping the patient walk around. I want that ambulatory therapist. Like, I want the person that's trained to do it. I want that physical therapist to be in, not the nurse. I want the nurse coordinating all the resources. And so that's, I think the other piece is what's the impact on all of these great professions, well-paying professions that create the middle class that we in New Jersey all want everybody to be a part of. Probably a little off topic, but that's kind of my take on it.
Well, I would love to have a continuation of this discussion. I mean, we haven't even really had the time to talk about your advice on, how the non-healthcare businesses around, our group can positively impact, outcomes and really positively impact social determinants. And really, make a difference in how our employees and our employees' families are being treated. So it's a huge undertaking. I think that this was a wonderful conversation, and I thank you for taking the time. And I think I would like to invite you back. Anyway, thank you so much.
Thank you. I really appreciate it. Listening, appreciate the question, and, appreciate the partnership. When I see all the hospitals that are sitting here, face to face on the Brady Bunch board of Zoom, I also know that they're not just the hospital in their community. They're the partner, they're, you're a vendor to them, you're, many other things, not just like a nice place to network. It has become something so much greater, and it's helping to propel the entire economy in South Jersey forward. And I think as we continue to do it, it helps us to also get to those big questions that all employers, even hospital employers, have, that are around what can we do so we can, help to control, some of the things that impact costs and are those pocketbook, kitchen table, sort of conversations. So thanks so much. I appreciate everybody having me in.
Thank you.
I'm just wondering if any of the representatives from the hospitals on the call, and thank you all for being here, by the way, if you have any next steps that you see we might be able to assist with, and I don't even know what they are, recruitment, or I hate to keep having meeting after meeting and talking to people about a problem that everybody is aware of, but I'd rather offer some assistance in any way you see that you can use the Southern New Jersey Development Council, something a little more hands-on, or something that's a little more meaningful than us talking about a huge problem. And the one that really scares me is the shortage of healthcare workers, particularly in the nursing community. But, I'm looking at it from a distance, and each of you in the healthcare business know much better than I do what might be needed and how we might be able to help.
This is Aaron. Kathy, great presentation, by the way. And you touched on a lot of salient points. And Marlene, I guess if you're asking for a practical suggestion, I know somebody said this during the forum, is so if you look at this really upstream, it's really making sure that we have more individuals in the necessary programs to produce the workers that we need. Ultimately, whether it's nursing, difficult ancillary positions. And I think a lot of times, and I've been fortunate to be in the California market, upstate New York market, now here, that's where I think, practically speaking, we've been able to kind of make a dent. So if there are local programs and, obviously with more offerings in the areas that's needed for each of the healthcare systems, but also more importantly, generating the interest on the front end, whether it's through the high school, the career fairs, the usual areas, I think that's where, if we can really gather the right group of people to think about, how do we generate more interests? How do we build a strong pipeline going into the future, not just short term, midterm, but long term, so that we can generate, that workforce that we're all looking for. So those are my thoughts.
Yeah, agreed. All right, well, we are approaching our end of time, but I did want to just touch on, if we could, what we're anticipating. We're planning to schedule our new health commissioner, Dr. Kaitlan Baston, for our next meeting. We want to talk about what we might want to present for her as topics, knowing what some of her focal points are. Obviously, she's interested in health disparities and improving maternal health outcomes and integrating substance use and behavioral health care. So we know those are some of her hot buttons. And, we have just discussed here some of the really important issues that we have in our minds. So I guess there's two things: how, what do we want to suggest to her specifically, and where do we want to have the meeting? I know there's a couple institutions that, might be interested in hosting. And I guess we'll be at the mercy of Dr. Bastion's schedule in terms of when it will be, but those I think are the things we want to try to focus on for the next minute or two.
I'll just chime in there, Kendria. We do have, we are kind of back and forth with her office trying to pick a time either in May and June. And I know Alyssa, who's not on this meeting, unfortunately, she's off site right now, has been talking with Kathy Scullin. And we're hopeful that we can find a time in the next month or two. And Inspira has generously offered their facility to be the host. So we have the location. We just need the date and time. So stay tuned on that front.
Oh, great. Okay. Well, that just very quickly wraps up that portion of the agenda. Are there any other comments or suggestions for a future meeting?
I would just think that, and since Bob Wheel is on the call, Bob co-chairs the Business Development Committee. I would think that if we do another Zoom meeting, well, and we will at some point, I think it would be very helpful for the business community to be invited onto a call similar to this one, to understand how important. I know they know it's important. We know that, but if they heard the specifics that we heard today, I kind of think they would be surprised and eventually a little more engaged. I don't know, but it just seems that as Kathy was talking about going through the slides and talking about all of the issues, it very definitely involves a partnership with the business community, even though we're all in the business community. But I'm thinking that Bob's committee might be a good partner to a discussion similar to this one.
Good idea, Marlene.
Yeah.
And we may want to invite the workforce development community as well. We heard mention that, we should be reaching out to folks in high schools and that type of thing to tap into the, future talent. The workforce development programs around the state have all kinds of programs regarding incumbent worker training. They have career pathway programs. I know they work in conjunction with a lot of the hospitals currently, but this might be that arena that pulls it all together.
Yeah, I'd like to see that happen. Good. All right. We are at 12:05. Any further comments before we say adieu? All right. Well, thank you all. It's been a wonderful meeting, very productive, and I look forward to seeing you all again. Thank you.
Thank you all.
Thank you.